Seguimos con el doctor Stewart Tepper con su tema Current Status of the Therapies Developed for Migraine.
Okay. So now I'm going to switch from trigeminal autonomic cephalalgias to current migraine therapies. Again, my disclosures, which are extensive and which I showed you before. Let's switch from cluster with its unusual central generators to migraine in terms of pathophysiology. Migraine has a peripheral set of pain mechanisms. And these pain mechanisms, which occur in the meninges, are likely caused primarily by the release of calcitonin gene-related peptide, or CGRP, which causes both vasodilation and inflammation in the meninges, as you can see in the upper left. Migraine has complex central functional connectivity involving the hypothalamus, the dorsal raphe nucleus, locus ceruleus, and the trigeminal nucleus, the trigeminal cervical complex, including the trigeminal nucleus caudalis. One way to think about migraine is that one can affect migraine centrally, or one can affect migraine peripherally by targeting the CGRP. There are multiple data which highlight the role of CGRP in patients with migraine. And the advent of the CGRP, anti-CGRP therapies is an example of translational research made real. CGRP concentrations rise during spontaneous migraine attacks in the external jugular vein and fall interictally and after sumatriptan injection. Intravenous infusion of CGRP in migraine patients triggers migraine attacks in those with migraine over the next 2 to 4 hours. And then, of course, the important outcome, blocking or removing CGRP can terminate migraine acutely and can prevent migraine. I put together a cartoon to show where CGRP could play a role. Triptans and ergots activate the serotonin 1B and 1D receptors. The 1D receptors prevent the release of CGRP, seen here as the blue spheres. There's also a 1F receptor located here, and lasmiditan, when it binds to the 1F receptor, also prevents the release of CGRP presynaptically. Triptans and ergots also vasoconstrict blood vessels that are dilated by CGRP, and I'll come back to that. Here's the transmembrane CGRP receptor, the canonical receptor, which has a cyclic AMP activation and results in vasodilation and neurogenic inflammation when activated. And here is the CGRP in that receptor. Onabotulinum toxin A prevents CGRP release as well, and so triptans, ergots, lasmiditan, and onabot all prevent the release of CGRP and prevent the CGRP from getting to the transmembrane postsynaptic receptor. CGRP receptor antagonists are called GPANs. These small molecules block the CGRP receptor, and they include ubrogepant, rimegepant, atogepant, and zavegepant. One can make a monoclonal antibody against the receptor, and that is arenumab. Or one can make a monoclonal antibody against the circulating CGRP ligand, and that is what fremanezumab, galcanezumab, and eptinezumab are. Triptans and ergots, through a serotonin 1B activation, vasoconstrict the vasodilated vessels that CGRP dilates, and nonsteroidal anti-inflammatories reverse the neurogenic inflammation that CGRP initiates as well. Let's move to the acute treatment of migraine. First, let's talk about ditans. There's one ditan that is approved in the United States, lasmiditan. And this requires going back to our old friend, serotonin as a target. Remember that triptans and ergots bind to serotonin 1B and 1D receptors. So the 1D receptor inhibits CGRP release, as does the 1F receptor. The 1B receptor constricts the blood vessels that CGRP dilates. Here's the release of CGRP by trigeminal nerve fibers. Lasmiditan also activates serotonin 1F receptors centrally. And it is probably the central activity of lasmiditan that is most important for the anti-migraine effect. Lasmiditan was approved last year for the acute treatment of migraine in adults in the United States. And because it activates the 1F receptor, but not the 1B receptor, it lacks vasoconstrictive activity and is appropriate for patients with vascular disease who were included in one of the regulatory trials. 2-hour pain freedom is very similar to the fast-acting triptans, such as sumatriptan or rizatriptan, but because it has central activity, lasmiditan can cause dizziness and somnolence, and patients are advised not to drive or operate machinery for 8 hours after dosing, even if they do not have CNS adverse events, because it's been shown that lasmiditan affects coordination centers when the patient is not even aware of it, and simulator driving studies showed weaving by patients who took lasmiditan and did not report any adverse events. Lasmiditan, as a centrally active drug, has some governmental control in the United States. Gepants are also approved in the United States for the acute treatment of migraine. And remember that they block the CGRP receptor. 7 have demonstrated effectiveness in acute migraine treatment. 2 are FDA approved, ubrogepant and rimegepant, and they prevent the CGRP-induced vasodilation. They do not vasoconstrict, and so unlike triptans, they have no warning about use in vascular disease, and they are being prescribed in patients with vascular disease who cannot take triptans or ergots to terminate migraine acutely. Zavegepant is a third one being studied for acute treatment. Ubrogepant is available only as a tablet, rimegepant only as an orally dissolvable tablet, melt, or wafer, and zavegepant is being developed as a nasal spray. The 2-hour pain-free response for all 3 of these is about 20%. So lower than the fast-acting triptans and lower than lasmiditan. The FDA also requires that all of these new acute medications relieve the most bothersome symptom that the patient chooses from photophobia, phonophobia, or nausea by 2 hours versus placebo. But 20% pain-free is what you get with a Gepant. What you also get is an absence of side effects for most patients. They are extremely well tolerated with minimal side effects. It is extremely rare for me to see any side effect at all with them. So although they appear to be a little bit slower in onset, patients can take them during the day and not worry about side effects. And that has been great. The AHS, the American Headache Society, published a position paper last year as to who should receive these new drugs, and they suggested that patients who have contraindications to triptans, that is vascular disease, or a lack of adequate response to at least 2 oral triptans, or a lack of tolerability with at least 2 oral triptans, should be allowed to access the new treatments. And they recommend that the older medications be tried on at least 2 attacks each to evaluate efficacy and tolerability. But it turns out that's a lot of patients if they have adequate insurance coverage, because a lot of patients do have adverse events associated with triptan use. Let's move to prevention. The problem with prevention in our oral migraine preventive medicines prior to 2018 was that all the patients stopped them. There was a study by Hepp and David Dodick that was published in Cephalalgia in 2015 of 8,688 patients in a database analysis of patients given patients with chronic migraine given oral preventive medications, and 83% of those patients discontinued their preventive medicines over a year. In the second International Burden of Migraine study, the patients were asked, why did you stop the drugs? There were 1,165 patients asked this question, and the answer, not surprisingly, was lack of efficacy and or the side effects. So it has been an exercise in clinical futility to prescribe medications to patients in whom 83% are going to stop them in a year. That really resulted in pent-up demand for new, adequate, well-tolerated prevention that the monoclonal antibodies have addressed. They are large molecules that do not pass into the brain. They work peripherally to prevent migraine, and they are removed by the reticuloendothelial system, not the liver. On the right, you see Dr. Sen Xu, who was the scientist who developed erenumab. The size difference is that the monoclonal antibodies are the size of a truck, while the gepants are the size of a grain of rice. These are the 4 injectable monoclonal antibodies to CGRP or its receptor. Erenumab on the left is available in a monthly subcutaneous dose of either 70 or 140 milligrams with an autoinjector. Here you see the antibody going after the CGRP receptor. The other 3 are, target the CGRP ligand, not the receptor. So you can see each of them is going after the blue sphere of CGRP. Fremanezumab is available in a monthly or quarterly subcutaneous injection with an autoinjector or prefilled syringe in the United States. Galcanezumab is FDA approved for migraine with a loading dose of 240 milligrams and 120 milligrams subcutaneous thereafter, again in an autoinjector and with a prefilled syringe. And galcanezumab, as I just mentioned, is the only approved medication for prevention of episodic cluster headache with 300 milligrams subcutaneous as 3 injections of 100 milligrams sub-Q across the abdomen in prefilled syringes each month to the cycle end. Eptinezumab is the only monoclonal antibody which is administered intravenously and quarterly in either a 100 or 300 milligram dose. But all 3 on the right are monoclonals that target the CGRP ligand. All of them are approved for both episodic and chronic migraine. Are they safe? Are they different than what we had? And are they an improvement? Safety has been very reassuring. The most frequent side effect for the self-injected monoclonal antibodies is an injection site reaction. The most frequent side effect for eptinezumab are respiratory symptoms, not always greater than placebo in the studies. Constipation can occur with all of them. It has a special warning in the US prescribing information and has also been noted for galcanezumab in the EU prescribing information. And I'm here to tell you I've seen it with the 3 on the left in patients. So I do ask patients about it and warn them about it. Hypertension has a new warning in the US erenumab prescribing information, but I have not yet met a single clinician anywhere in the US who's ever seen significant hypertension with any of them. So we don't know if this is an excessive warning. And in terms of whether taking out the CGRP or its receptor could put people at risk when they need to vasodilate in the setting of ischemia, intravenous orenumab, not subcutaneous, but intravenous orenumab, 140 milligrams, was given to angina patients in a randomized controlled trial, and there were no infarctions, no worsening on stress tests, and there have been no cardiovascular signals from 1 to 5 year open label treatment trials in these 4 monoclonal antibodies. Because they are a new therapy, we need to be clinically vigilant. But boy, the tolerability and safety so far has been fantastic. Let's talk about efficacy. All of them reduce mean monthly migraine days. All of them separated from placebo in studies in less than a week. And this was for both episodic and chronic migraine studies. All demonstrated meaningful clinical benefit by 1 month in the studies. All showed unprecedented 75% or greater responder rates, unlike older drugs. All work in patients who have had at least 1 to 4 previous preventive medication class failures, and these were studied in randomized control trials prospectively. And when treated, the majority of patients convert from chronic migraine to episodic migraine, and from acute medication overuse to non-overuse, and all show continued improvement over years of use with no safety or tolerability concerns. So they seem very, very good, like a paradigm shift. But how can we evaluate whether they are superior to previous migraine preventive medications? We hear a lot about therapeutic gain, the active response minus the placebo response. The reciprocal of therapeutic gain is number needed to treat, or NNT. And for NNT, the lower the value, the better. You don't want to have to treat a lot of patients before you see benefit. Therapeutic harm is the active adverse events minus the placebo adverse events. And number needed to harm is the reciprocal of therapeutic harm. For NNH, or number needed to harm, the higher the value, the better. You want to treat a lot of patients before you see side effects. The NNH to NNT ratio is the likelihood of being helped or harmed. And the higher the value, the better. And that ratio describes the value of an intervention as a benefit risk analysis number. The higher, the better. And if you are going to do placebo subtracted analysis of effectiveness, you must include the adverse events as well to give yourself a complete picture of the effectiveness of a new treatment. And here is the master slide, which shows the NNH to NNT data, the ratios for galcanezumab, orenumab, topiramate, onabotulinum toxin A, and propranolol. And you can see the NNH to NNT ratio for topiramate, onabot, and propranolol is in the 2 to 4 range. The NNH to NNT ratio for the monoclonal antibodies is in the 14 to 167 range. Often it is dramatically higher than the older treatments. And this identifies the benefit of these monoclonal antibodies from the conventional preventive treatments and shows us with placebo-subtracted analysis that the paradigm has shifted. These drugs are better if one takes into account efficacy and adverse events. Let's go back to the GPANs. Remember, they are used for acute treatment of migraine, but it turns out they can be used for preventive treatment of migraine. In open label trials, the more the GPANs were taken for acute treatment, the fewer the migraine attacks that people recorded. So atogepant has been studied in a daily dosing, which was positive for reduction of mean monthly migraine days in episodic migraine, and published in Lancet Neurology in the last couple of weeks, and is in a regulatory trial for prevention of chronic migraine. The magnitude of decreased mean monthly migraine days in episodic migraine for atogepant was similar to the monoclonal antibodies. Rimegepant in every other day dosing has a positive study that has not been fully published yet, but presented, suggesting that every other day dosing could be effective in prevention. Anticipation is that it will be submitted for regulatory approval this year, and rimegepant would be the first medication approved for both acute and preventive migraine treatment. Who should receive the new preventive treatments? Most regulatory authorities and payers across the world require a lack of success with at least 2 of the older preventive medications or on-botulinum toxin A if they have chronic migraine, and the AHS position statement stated the same. But the problem is that in the US, which is a pretty rich country, Richard Lipton presented data this year from a study of over 20,000 people in the population, and of 5,873 with at least 4 migraine headache days per month and moderate or severe disability, and 85% of them did not get through 3 steps: seeking care, getting diagnosed, and receiving at least 1 preventive treatment. So doing the step edits to get to the monoclonal antibodies may be excessively tough, and we may not be matching patient need to the new drugs that we have. I'd like to leave you with a quote on this particular study from Dr. David Dodick, chair of the American Brain Foundation. I see a day within our careers when it will not be acceptable to treat patients by having them cycle through a ragtag group of drugs that over 80% of patients will stop within a year just to get to disease-specific and mechanism-based treatments that were specifically designed to treat this disease. Thank you, and I will pull up my third talk.